Hello, everyone, and welcome. Welcome to Backchat. Welcome to Move with Scoliosis. So this is your channel for those of you who are new here, for everything movement, yoga, Pilates, for those with scoliosis. And I can see some of you already tuning in, which is fabulous. So if you are able to, obviously make sure to ask your questions today. So I do have a guest on here today, and we will be talking about spinal fusion surgery, especially. So if you have any questions about this topic, make sure that that you ask them in the chat. I obviously have my own questions because I'm really excited about talking to my guest today. But again, if you are new here, I have been doing this work since 2015, but 2017, I think, was when I started to post YouTube videos. So on this channel, you will find a huge variety of practices. So it's kind of my own practices that I've shared, that all the things that I've learned over the years from myself and suffering from scoliosis myself, but then also working with clients, obviously, as a yoga teacher. And this will be people with mild scoliosis, very severe scoliosis, and those with spinal fusion. So there is a huge amount of content on this channel, which is why I have created a little quiz. And that's a new feature. So you can find that in the description, where you just answer a few questions. And then basically it will take you to the content that might be most relevant for you. So that is just something for you to explore. But let me get on to introducing our guest today. So we've got Dr. Fady Sedra here, and he is a spinal surgeon at the Royal London Hospital. And let me bring him on. There he is. Hello, how are you?
Hello, Christine. How are you? Thank you very much for having me on your channel at YouTube.
Yeah, thank you. Thank you so much for taking the time, obviously, to talk to me today. And we originally met at an event. Well, I met you. You didn't meet me at that time, but you were presenting, obviously, for the Scoliosis Association. And I thought it was just such a nice and very down-to-earth presentation that I thought I must get him on to this channel here, because I always get asked questions about spinal fusion surgery. And obviously, I haven't had it myself. It's not an area of my expertise, but I think it's very relevant. And I obviously work with a lot of people that have had spinal surgery. So thank you so much for being here.
No problem. Thank you for having me.
Good. So I thought maybe we start with a little bit of kind of an overview, and especially, obviously, so there will be, I assume, teachers, so yoga teachers, maybe Pilates teachers, or other movement specialists as well, tuning in. There will be people who are maybe considering having spinal surgery, and then people, obviously, who are trying to avoid it as well, as much as possible. So I was wondering, how has kind of that spinal fusion surgery changed over the years? Because I think last time we spoke, you were saying, I think it's only about 50 years old, this this whole surgery. Yeah.
So essentially, I mean, we started off with quite a few years ago, actually, with what's called the Harrington Rod, which involves just a single inserting a single rod that has two anchor points, one at the top of the spine and one at the bottom of the spine. And this was the earliest generation of instrumented spinal fusion. Obviously, at that time, it was revolutionary. And however, we saw over time, I still treat some patients with Harrington Rod in the fact that it did not really respect the harmonious curves in the back. So it ended up fixing the backs in a flat position. And that obviously, that's not how our backs are designed to function in real life. So with all the problems that comes with it, years after the fusion, including back pain and what we call a flat back syndrome.
Mm-hmm.
And then gradually we moved into what's called a segmental instrumentation, where we understood the spine mechanics a bit better. And we now know that the spine is actually formed of segments, and you need to address every segment as a mobile segment on its own accord. And then the pedicle screw systems were developed, which involves inserting screws at every or at most levels of the segment that you're fusing. And that obviously allowed us to recreate the spine curves and respect them again, and fuse the spine in a functional position that respects the biomechanics and the weight transmission and so on and so forth. And we saw a massive change, or a massive improvement in the outcome of fusion surgery, and to the extent that, you know, with all the kids that I operate on for scoliosis and so on and so forth, they get mechanical back pain if the deformity goes beyond or progresses beyond a certain degree. This mechanical pain just dissipates after the procedure, because we took away the source of pain, but we also put their spine in a more functional position where they can transmit the weight of their head, upper limbs, and also to their lower limbs quite naturally, if that makes sense. So we moved on from the Harrington single rod into a segmental fusion at the moment, which is obviously quite an improvement in the design, in the materials, in the recreation of the spine curves, and obviously subsequently in the overall outcomes.
Yes, so that very interesting. So Harrington Rod, for any kind of yoga teachers out there, maybe what sort of time frame are we looking at? Like, when would those people have had the surgery?
So that would be around the 60s, 70s, and 80s. It depends where the surgery was done, to be honest with you. And then there is a transitional period in between where we used what's called sublaminar wires. So we used wires attached to certain points in the spine, and we fixed that to rods before we moved into the pedicle screws. But the patients would know what they had. They always come in clinic saying, I had a Harrington Rod put in, and so on and so forth. So they will know what was put in. They will have X-rays. If you see a straight rod in the back, I mean, having said that, obviously it did fill in a gap, as in, you know, in these days, if you leave the scoliosis to progress, that would eventually lead to other problems like respiratory function embarrassment and severe mechanical pain and so on and so forth. So, not to say that it was all bad, but at that point in time, it did sort a problem. But seeing the 10 years, the 15 years, and even the 20 years follow-up of Harrington Rod, overall, it did cause some issues in these generations.
So the Harrington rods are basically the people that don't have any movement really at all in their spine. Is that right?
Well, to be honest with you, I mean, even with the segmental instrumentation, we take away some of the flexibility. But this is another improvement in the spinal, in the recent generations of spinal fusion, is that we always endeavor to fuse less segments of the spine. In the Harrington, in the generations who had Harrington Rod, there was no much choice in terms of, they ended up fixing a bigger proportion of the spine and stiffening it up subsequently. So with fusion, the spine is stiffened up, all right, but it depends which portion of the spine do you include. So at the moment, with the increased knowledge around how the different types of scoliosis behave, we have the opportunity to fix or fuse a smaller portion of the spine, right?
Right.
And also we've seen the with the long-term follow-ups of patients who had fusions down into their lumbar spine and fusing a substantial proportion of their lumbar spine, which is supposed to be the flexible part of the spine. Now we try as much as possible to refrain from fusing most of the lumbar spine or even get into the lumbar spine. So you would hear something like selective thoracic fusion, where we try not to get into the lumbar spine at all as much as possible. And this would again leave few flexible discs for the patient to be able to function on, if that makes sense.
Yes, yeah, absolutely. Because for for overall balance and movement, it's obviously much better if you can move that part of your spine, isn't it?
Absolutely right. Absolutely right. Absolutely right.
You kind of answered my question as well about the curvatures, obviously, that you're flattening, or that were flattened before, maybe not so much anymore. But I see that in yoga and Pilates, we sometimes talk about the neutral spine position in our movements. But I always find that people who've had a spinal fusion, that kind of goes out the window because it is all a little bit, it's all a little bit different. And especially if people have had a thoracic fusion and their upper back might be quite flat, everything works just slightly differently.
Absolutely. I mean, obviously the ideal scenario is that the scoliosis is not severe enough to have fusion, right? Even if we fuse only the top part of the spine, which is the thoracic spine, which is splintered by the thoracic cage, and there isn't much movement there. Ideally, they do pay with their flexibility just a bit, right? But I mean, I always quote one of my patients who used to be a professional dancer, and unfortunately, he had a particular subtype of scoliosis, which is mainly within the lumbar spine, and then he was quite severe, and I told him, well, he will continue to progress. However, you need to understand that he might be you might need to think about a different career, because once I fuse your lumbar spine, your dancing career will probably go out of the window. The guy was he was very insistent that he will have the surgery done and that he will make it work, and he actually made it work. And he came to see me a few years after, and he continued to dance despite the fact that I stripped him off or most of his flexibility. I guess what I'm trying to say is, it all depends on the enthusiasm and keenness and what you want to do with your life. And I always tend to encourage my patients to push the boundaries a bit more, to try to achieve a bit more, to try not to succumb to the muscle, because eventually after these surgeries, the muscles might get a bit deconditioned, as you know, and that's where you guys come in terms of, you know, yoga, Pilates, trying to squeeze every single degree of flexibility out of my patients' spines. And I really cannot thank you guys enough in terms of, because we complement each other, and I like to see it that way, because it's no point me showing excellent x-rays, but my patient has not achieved what they wanted in life. And there's no way that they can achieve that without someone like you and your colleagues who can help them recondition their muscles, which is very, very, very doable. I can push from my side, but I can only direct them to show them the right path, and it's up to them to take it or not. But I've seen it. I've seen so many of my patients who went down that route of rehabilitating their back, and pretty much they went back to sports, they went back to their life, they went back to their activities. They don't even feel that they've had surgery. They went back to running, even high impact exercises. I have patients who've been running for years then since they had the spinal fusion. They're training for marathons and stuff like that. I've seen all sorts, Christine, to be honest with you. But it is
Amazing.
down to the personal view of life and what they are willing to do and the decision to achieve and to make sure that this type of disease or surgery or whatever is not going to stop them from achieving what they want to achieve.
So is there ever anything where you say, that's not for you, don't do that? Or do you kind of say, go on with your life and do the things you want to do, and your fusion will tell you what you
So
can or
essentially,
can't do?
different from one patient to the other. It depends
Mm-hmm.
again what type of deformity they had in their spine and what they are willing, and what type of where did I stop with my fusion. Essentially,
Mm-hmm.
the critical time is probably the first 9 to 12 months after surgery, where the spine is fusing and the surgery is taking as we say, if you like. After that, the patient is pretty much free to do what they want to do. But for
Right.
example, if they there are things we have to set the expectations, Christine. For example, I've recently seen two young patients who are in football academy. All right, and they have scoliosis, and they need fusion surgery. So we know from literature that if we go below L2, for example, in the fusion, sprinting becomes a bit challenging, a bit difficult. So it's not
Mm-hmm.
about me telling them what to do and what not to do, but it's really setting the expectations right. Okay, because sometimes as I said, careers are involved there. So if he's in football academy aspiring to have a career in football, again, it is not black and white in most occasions if they should have fusion surgery or not. And sometimes it depends on the patient and what they do and what they aspire to do. And it's always a conversation with the patient. And I always support my patients with all their decisions. All right. For example, one of these patients, he didn't come back to clinic. The other patient continued to come back and see me, and
Yeah.
we settled to follow up this curve and see where it settles. But particularly that it's not causing any issues at the minute, and because it is sort of a gray zone, if you know what I mean, as in it's not a very severe deformity. We can sit on it for a bit. I said he was very compliant in what I said. I said you will need an astringent course of physiotherapy, and you need to change the lifestyle a bit to involve a bit more yoga and Pilates into your daily routine in order to keep your muscles in shape. Once you let that go, then the back pain will start, and then it all goes to pieces. And it's good on him. He's been following this so far, and things are going well. So that's what I'm saying about supporting my patients to achieve what they want to achieve. It's not all about taking patients to theater and operating them and producing good x-rays, if you know what I mean.
Yeah, yeah. So this is really leads in well with my next question. How do you how do you decide, or that you might, because obviously you don't make the decision for them, I guess you are suggesting that one option might be to go down that route and have surgery.
Yeah, I mean, when it comes to spinal deformity, it's not really easy because there are so many factors in play at the same time, including the magnitude of the curve, the shape of the curve, the type of curve, the position of the curve, but also things around the patient, how old they are, how much growth are they left with, and also what they do in life, what they are aspiring to do, and how much is this curve problematic
Mm-hmm.
to them, and the we have to piece the puzzle together, if you know what I mean. All right. And it all depends about, listening to the patient, examining the patient, and there is no place in spinal surgery for any rash decisions.
Right.
We take our time. We meet several times. All right. We discuss together. We get to know each other very well. All right. And I always tell my patients, the younger ones, that this is a doctor-patient relationship which is likely to continue for years. All right.
Mm.
And over time, I do understand the patients well. I mean, um, for example, I met one of my patients recently in clinic. She was a young girl who is moving into university, and she has a moderately severe curve, one that we can treat um, conservatively or surgically, depending on how the patient sees it or wants it. And then she always kept quiet, but for some reason I could see in her eyes that she might want to have it operated on. And I insisted. At one point I said, okay, fine, it has not progressed over time. It might be the time that I discharge you from clinic. We have followed it for sufficient period of time and it didn't show any signs of progression. Parents were obviously happy with this decision, but and then as I was leaving the clinic room, I actually came back, sat down, and I said, well, listen, I don't feel that you're satisfied with this. Please do let me know what you're thinking. And I kept insisting up until she opened up, and she was actually cosmetically very disturbed by the curve, and
Mm-hmm.
we ended up, changing the conversation completely. So that is what I'm talking about in terms of having a doctor-patient conversation about what is troubling you with this curve and how it is affecting you. And at the end of the day, we together make a decision on how we're going to address it. Equally,
Mm.
I've seen a 17-year-old recently who has a moderately big curve, but she's not at all bothered by it. And we ended up saying, okay, let's watch it for some time. Keep it at the back of the head that we might need to consider surgery if it progresses or not.
Mm.
So it's not always black and white. There are so many
Yeah.
factors in play, but the key is the tailored approach for every single patient, if you know what I mean. Like
Mm.
it's not one size fits all.
Yeah, sure. Is there kind of is there I'm just thinking about those people maybe who decided not to have surgery, and then maybe later on in life they're having more problems, or they find it starts to progress. Is there kind of a benefit of doing it early rather than later, or can you even have a surgery later on?
That's an excellent question. So there is an increasing reports in the scientific literature about early management of scoliosis curves, but only in a neuromuscular disorders or in patients with neuromuscular disorders. But it's a very particular subset of patients where they have disease within the disease that affects the muscles or the nerves. There is usually some learning difficulties and so on and so forth involved. And with time, the general health starts to deteriorate a bit. And therefore, there were the studies that were published not very recently, started off a few years ago, that says that there is something to be said about catching these curves early, because where the patients are much healthier, and fusing it and allowing the patient to pursue a healthier, more comfortable life.
Mm.
However, when we speak about adolescent idiopathic scoliosis, where there is no issues with the nerves or the muscles, it's a slightly different kettle of fish, where we where we have to be very careful with the decision making. At the end of the day, the curve has to pass a certain level or a magnitude or a degree where we would start having conversations. And again, it depends on where the patient is in terms of skeletal maturity. For example, if I see a 40-degree curve in a 9-year-old is different from seeing a 40-degree curve in a 14-year-old girl or a 15-year-old, 16-year-old boy. The latter it's more or less skeletally mature. So in the younger kid, I would say, well, this has to be addressed sooner rather than later, and we have to really be aggressive with this curve. Otherwise, there might be some detrimental effect on the breathing, on the lung growth, and so on and so forth. But in the 14 or the 15 or 16-year-old kid, we can have a slow-paced conversation where we say, okay, it's a 40-degree curve. It's a gray zone. We can follow it up. There is a particular style of life that should be pursued in terms of keeping active, keep exercising, keeping your muscles always in shape, and that could keep the back pain and all the other bits and pieces at bay.
And
so
what? Yeah, sorry. Go ahead.
Yeah, and then I just leave a note there that I'll see them maybe once every year, and examine them clinically and say, listen, I'm here. My colleagues are here. We're always ready to address it, because we didn't find any difference, to be honest with you, if I address the curve between addressing the curve at the age of 16, 17 and the age of 20, 21, 22. The issues comes when if it is a much bigger curve, and then we say, well, we might need to have a different conversation here, that we might need to think about fusing the spine, because it goes in beyond 45 or 50 degrees. It sort of goes into autopilot, as in it will grow by a small percentage every year, and there is something to be said about catching it now rather than in 10, 15 years.
Yeah, I mean, so I think this kind of range, I do see that quite often, actually. Most of my clients are older. So let's say we've got like a 40 or 50-year-old who's got kind of a 50-degree curvature. Is this something where you say, we just monitor it and see what happens, or is this something where you say, no, we need to kind of address this early, or can they go and live a long and happy life until they're 99 and it's fine?
So that's again an excellent question. So essentially, what are they troubled with? Okay. If I see someone in his 50s or 60s with back pain and scoliosis, which is not uncommon, I do see them. A few of my patients fit this category. I say, what is troubling you with your back? If it is back pain, then we need to find where the back pain is coming from and address it. Obviously, I'm a spinal surgeon. I'm trained to do spinal surgery to a very good level, I would say. But the impact on the patient is something different, if you know what I mean. All right.
Yeah.
So those patients, those guys who come to you to seek help with yoga, Pilates, and stuff like that, if I operate on them, that takes them out of your rehabilitation program for quite a while. All right. So we have to balance the risks against the benefits quite carefully, all right? As they say, we have to be careful with any decision that we make at this point in time. And when I treat their pain and push them back into rehabilitation, persevere with the conservative option, I think that has a much better outcome with regards to these patients. Yes, they have to be under some sort of a medical supervision, as in get themselves checked probably once every 2 years, I say, or once every year. It depends. Again, it depends on how they're bothered with it. You know, if
Mm-hmm.
it is pain, I can find where the pain is coming from. I could treat it. I could make them more mobile, and then I can push them back into physical rehabilitation and make sure that they pursue a healthy lifestyle, and then life goes on. The what I'm trying to say is fusion surgery is not always the answer.
Right.
I do it a lot, and I operate a lot, but I also operate on patients who understands the pros and cons of having this procedure done, and what are we looking at the other end of this procedure. All right,
Mm-hmm.
and then have a decision made. And also we have, in the older age group, it's always better to consume all conservative avenues before considering a fusion surgery. And one last thing I would say in this respect is um, nowadays we do not treat patients as a single medic or a single professional. All right, we treat patients in a multidisciplinary environment. Okay, because these patients would have a multiple requirements, as in particularly those who have been, you have a first-hand experience of that. Any patients with scoliosis is always in the background of their lives, if that makes sense, all right?
Mm-hmm.
And they might have, so I see patients who were offered surgery as a youngster, however, they were too afraid to have it done at that point in time, or the social circumstances did not allow it. And then they come later on in life and say, well, can I have it now? But we have to understand why they want to have it now. All right. Is it the body image? Is it the pain? Is it the actually that the function is deteriorating? Is the curve is getting worse? We have to understand why. And I do not function alone. I do not act alone. I am a part of a bigger team called Complex Spine London, where we have other surgeons, pain management consultants, psychologists, rheumatologists, physiotherapists, radiologists, and so on and so forth. We meet regularly. We discuss complex cases similar to patients with a spinal deformity, and then I would say, please, can you? I'll tell my colleague who's specialized in pain management, for example, can you please see this guy, or and that he has this issue with the pain, and then we scrutinize their images very well, trying to find out where the pain is coming from. They see my colleague on the other side, and then my colleague would say, yes, I found out where the pain is coming from. However, I could see that his muscles are extremely deconditioned, and then in turn they speak to the physiotherapists in the group, and then we gather again and say, where is Mr. Smith or Mrs. Jones is at the moment. Does that make sense? So
Yeah, absolutely.
it's not just diffusion surgery. The best way to address these issues in this day and age is in a multidisciplinary environment where everyone sits in a round table, discuss the patient. We actually have what's called an NDT clinics, where we arrange a date and time and a place where I will gather with my colleagues, see a patient collectively in clinic, and examine them, listen to them, and have a discussion with them, and say, yeah, that's the plan, and we agree all the plan, patient involved. Does that make sense?
Yeah, absolutely. I've heard that a few times before, that it's like you need a team of people, really.
Yes. There is no place now for a surgeon treating patients, from start to end, where it's the at some point, I put my hand up and I say, well, the answer is not a fusion surgery. Okay. Sometimes I say that. I mean, more often than not, I say that. But sometimes I say, well, I'm not ruling out surgery, let's say, but first of all, let me discuss it with my colleagues. You might end up seeing a different part of different member of my team, All right,
Yeah.
you will understand the logic and the philosophy behind it. Okay, and we are now more and more seeing patients who understand this concept and then understand this philosophy and approach and actually ask for it, which makes me feel really happy that we have established a service that provides a collective decision. And sometimes I get the pain management consultant and the physiotherapist saying, Fady, that's it. We've done it. We've tried our best. It's time to consider surgery. At which
Right.
point I feel, okay, bring the patient back to me. It's time to have a different conversation.
Yes. While you were talking, I was thinking about one client, and I've heard this a few times. Again, with kind of a severe curvature, and that they might have been told, these are people who haven't seen anyone for years, obviously, and maybe when they were first diagnosed as a child, they were told, well, your scoliosis is going to progress by 1 degree every year. That seems to be very a kind of a thing that has been said for a long time. And then they say to me, I don't want to end up in a wheelchair. This is always this is kind of the fear, obviously, of it's just going to progress and progress. And what if it's 60 degrees now and I don't know, 62? What are the next 10 years are going to be like?
So
What would you say
yeah,
to someone like that?
yeah. The thing is, there is a lot of myth around it. If you know what I mean, as in, I've never seen a spinal deformity or a scoliosis patients ending up on a wheelchair because they have severe curvature.
I'm
It
very
might
happy
have,
you're saying that. I'm
yeah.
very
I mean,
happy.
to be honest, yeah, it is difficult to challenge this thought in the patient's mind in clinic. I have to be very frank. But I've never seen this happen before. Sometimes in extreme cases, they might find it difficult to pursue their day-to-day activities as they wanted to be or as they used to do. But this is in the extreme of cases. Does that make sense? And even in these occasions, these patients might need a complex reconstruction, and it is when we reach the stage where the patient's day-to-day function has been severely impacted by the magnitude of the deformity and because with time and deformity, that means that the mechanics of the spine is disturbed and that the spine is degenerating quite quicker than in other individuals with no spinal deformity, if that makes sense. At that point, we are considering a complex reconstruction. Again, we have to be careful, very careful with this. I do this operation quite regularly, and thankfully, touch wood, my patients are happy so far only because they were well informed prior to surgery, and they were empowered to make the decision now that they understand exactly what they are signing up for. All right. The French spinal surgeons who invented this type of complex reconstruction in the older age group, they reckon that every patient will get some sort of a complication ranging from a very simple complication up to a massive complication. And once the patient is empowered with this information, then we meet several times in clinics. We try to understand what the issue is. We try to solve it with conservative means of management. And if that does not work and we're going towards surgery, then it's all about planning. Okay, planning the procedure quite carefully, having the setup to do it quite carefully, and again doing it in a multidisciplinary fashion will secure the best chances for success. All right. But that's not to say that every single patient with a spinal deformity will require a complex reconstruction. Thankfully, this is a small subset of patients with extreme problems. And even within the subset of patient, understanding what they want or what's the most troubling issue, we can do a smaller type of procedure that solves this issue and get them back into life, if that makes sense. So, for example, if a patient with a deformity comes into a clinic and then they say, "Oh, doctor, if you take away my leg pain, I'll be very happy. I don't mind the deformity that much." At which point I could say, "Okay, let's just simply decompress this nerve root, create more space for that nerve root, or do a limited fusion that would allow space for this nerve root or couple of nerve roots, and then they are much happier." We haven't done that massive of an operation that takes them offline for a year or a year and a half to recover from, but at the same time we solved the problem that was annoying them, and they are back into their functional lifestyle. They are back walking to their corner shop, coming to you to have their yoga classes, doing their shopping. They can go out with their grandsons or granddaughters to do some shopping or play in the park or something like that. And that's it. You know, we don't have to, as they say in these situations, less is more, if you know what I mean.
Yeah. So are these kind of the main, what I'm hearing are the main reasons for people having surgery is either pain or that they don't like the way that it looks. But so far I haven't heard anything of, oh, I don't know, your organs might not be working anymore if you don't have surgery or anything life-threatening.
I mean, again, thankfully we rarely face these situations, because these are really difficult situations, and that's why thankfully I'm really glad that they are not very common. But you know, for example, recently I've seen a girl who, because of the extent of the deformity, respiratory functions were very poor, but and now we are discussing what to do. Again, it's a complex situation, because in order to anesthetize the patient and do the procedure, they should have some sort of a there is a minimum lung function that needs to be there in order to perform the procedure. So it doesn't happen. I probably see this situation maybe once a year or once every 2 years, thankfully. But more often than not, it's a deformity that is not affecting any of the internal organs or the respiration or the cardiovascular system or the abdominal organs. Again, this is one of the myths that is going around, but it's not entirely true.
Well, I'm very, very glad to hear that. So I'm mindful of time. Obviously, I know you're a busy man. But maybe as a last one, what would you say are kind of some good questions to ask a surgeon when you're kind of putting yourself into the patient situation? Because I sometimes get this, and like that people say, "Oh, I don't really know what to ask."
Yeah.
What would be some good things to ask?
Yeah, I think a good start would be, what are the other options apart from surgery? All right, what can I do in order to avoid this procedure? All right, and there is always the conservative route to treat spinal problems, and I advise every patient not to rush into surgery. Have their time having all the non-surgical options quite carefully. For example, the item of physical rehabilitation, physiotherapy, yoga, Pilates. It's not just, oh, I had physiotherapy. No, I sit my patients down and I say, okay, who administered this treatment? How many sessions have you had? Show me the exercises that you've learned. All right. And then I make the decision, as in if this was a comprehensive course of physiotherapy, or I think you should see someone else, or I think you should see a yoga teacher or join a Pilates classes. And now everywhere there is Pilates for back pain. It is not rare. Everywhere, if my patients, I always encourage them to look carefully, they will find someone who provides these types of lessons and one-to-one coaching and so on and so forth. So make sure that you've done it correctly before you go into this type of procedures, and also exactly what the procedure entails, how many levels are you going to fuse, and so on and so forth, and which part of my spine is going to be fused, is also an important question. And what are we looking at in terms of the recovery time, in terms of the risks and possible complications? I usually quote all the risks with percentages, because I mean, some patients, their minds work with according to numbers, if you know what I mean. So it's not sufficient to tell them there is a risk that I might injure your nerves. Okay, doctor, what's the percentage in the general scientific in the general medical field, and what's your percentage of injuring the neural tissue? What are the risks of what's the percentage of having a wound infection and stuff like that? So it maybe just goes slightly more into the nitty-gritty of risks, complications, recovery time. When am I expected to go back to work? When am I expected to go back to exercise? What are the do's and don'ts, and when, and so on and so forth. So this is not jumping really into the future, but every patient needs to understand at least how they are going to function in at least the first 6 to 9 months, or even a year after the procedure. After a year, I think everything, if everything goes well, then the patient will be back into normal life and hopefully, resuming all normal activities. Is what I would say.
Great. Amazing. Yeah, some really good things here, I think, that people can take away from this. And yeah, thank you so much for this. This was amazing. And I saw there's lots of people watching as well. And yeah, I think that was great. So yeah, if you stay on for another minute or so, and we will just finish this live stream here. So thank you so much to everyone who was watching as well, and thank you so much, Fady, for answering all my questions today.
Thank you very much for having me, and thank you for all the work that you and your colleagues are doing. I've looked at your channel myself, and I would say the content is quite useful, and I encourage all patients with back issues to look into your channel and into other resources which looks at physical rehabilitation, because as I said, I mean, if the patient goes through good physical rehabilitation, pursue a healthy life style, we would see much less patients in clinic, and the number of patients, probably about not less than 30 to 40% of my patients, their problems are resolved by physical rehabilitation. So thank you very much for your effort, and for the efforts in yoga and Pilates, and also for your efforts in raising awareness about these issues.
Oh, thank you so much.